So good morning, good afternoon, good evening, good early morning to some. My name is Walmart James, and I'm a senior research scholar at Columbia University. And I'm calling in from a bright and sunny day in New York City to everybody scattered across the globe. And I wanted to say that we welcome you and welcome your participation in this final day of a symposium that dealt with COVID-19 and Africa. So today's session will be moderated by my colleague, Larry Stanberry. Before we get to that, I wanted us to just review the etiquette for Zoom used today by Harlow. Over to you, Harlow.
Thank you, Dr. James. Welcome back to most of you, and if any are just joining us today, welcome. We do welcome audience questions for the session today, and I ask that you please put your questions into the question and answer box, which is found at the bottom right hand of your screen. It says Q&A with some speech bubbles. Please, if you have questions, put them in that question and answer box. That way all of the attendees and all of the panelists can see your question. Please do not put your questions in the chat because other attendees will not be able to see your question or the answer. You also have the opportunity in the question and answer box to upvote questions from other panelists or from other attendees. So if you see someone has asked a question that you also would like answered, please hit the little thumbs up sign, which will upvote it and let the panelists know that they should answer that question. Back to you.
So colleagues, at the opening of this symposium, the Director General of the World Health Organization, Dr. Tedros, sent a message, and I thought it'd be appropriate before the last day of the meeting to just rebroadcast that. Even I can ask Harlow to load that message from Dr. Tedros.
Excellencies, dear colleagues and friends, on behalf of WHO, I'm honored to welcome you to this symposium on meeting the challenge of COVID-19 in Africa. We must learn the lessons of this pandemic for our response today and for the health emergencies of tomorrow. Let me offer 3 lessons we have learned so far. First, we're now seeing some signals of a downward epidemic trend in Africa, although several countries remain worrisome. Improvement doesn't mean it's time to relax. We must remain vigilant and not rush to remove safety measures we have put in place. Complacency can be deadly, and the threat of resurgence is a real one. A second lesson is that collaboration is critical to controlling the spread of COVID-19. That means working together across borders and across sectors. Nobody can take on this pandemic alone. Tackling this virus means we need to implement strong, evidence-based public health and social measures and to develop and provide equitable access to medicines, diagnostics, and hopefully a vaccine. But with or without a vaccine, we can only bring this pandemic under control by following the public health basics: testing, isolating and treating patients, contact tracing, and encouraging strong compliance with measures in communities. Which brings me to lesson 3. The most critical part of the response, public trust. Empowering communities and building public trust can only happen if we listen to communities and work with them to meet their needs. Trust must be earned by delivering on our promises. Last week, we celebrated the eradication of wild polio in Africa. That lesson is clear. The world can overcome any threat as long as we work together in solidarity. My best wishes for a productive and provocative discussions in the coming days. I thank you.
We are delighted to have Murugi Ndirangu give a very special welcome to all of the panelists and guests participating. And if I may introduce her as the director of Columbia's Global Center based in Nairobi. Dr. Ndirangu is an expert in public health, in policy and nutrition. She was formerly a professor in the Department of Nutrition and Healthcare Management at the Appalachian State University in North Carolina. A special interest is in nutrition, and particularly nutritional status of people that fall in vulnerable population categories. So thank you again, Murugi. Murugi is a fabulous colleague and has worked with us on a variety of projects.
Thank you, Wilmot. I'm delighted to be here. Good morning, good afternoon, and good evening to our global audience, and welcome. As Dr. James has said, my name is Murugi Ndirangu. I'm the director of Columbia Global Center in Nairobi. CGC Nairobi is one of 9 centers across the globe that were established by Columbia University to connect the local with the global, to create opportunities for shared learning, and to deepen the nature of global dialogue. Today, I'm delighted to welcome you to the 4th day of the COVID Africa meeting, the Challenge Virtual Symposium. The Columbia Global Center's Nairobi serves as a regional hub for research and collaboration as part of Columbia University's strategy to achieve global presence. CGC Nairobi links the continent to Columbia University's scientific rigor, technological innovation, and academic leadership. The COVID-19 pandemic has taught us that we have to work together to address global challenges. At CGC Nairobi, we strive to promote and facilitate the collaborative and impactful engagement of faculty, students, and local partners with the world to embrace understanding, address global challenges, and advance knowledge and exchange. The center provides students and academics with the base from which to conduct research in and for Africa. Some of the areas we work in include health, education, refugees and migration, business empowerment, and creative and liberal arts. Africa is a young continent, and by 2020, we'll still have the largest youth population in the world, with over 50% under the age of 25. This youth population surge could propel Africa into a growth trajectory that fuels industrialization and technological advancements. But we must first invest in quality education. CGC Nairobi hopes to contribute to the expansion of education opportunities in Africa because we understand that nations' growth and development and their capacity to innovate and solve problems such as COVID-19 with locally driven solutions depend on quality education. I am delighted to be here today to listen to our distinguished panelists. Let me now hand it back to Professor James. Thank you.
Thank you very much indeed, Murugi. And thank you for your leadership and for the work that you do out of the center in Nairobi. So it's now my pleasure to introduce to you the moderator for today's session, friend and great colleague, Larry Stanberry, who's the Associate Dean for International Programs and the Director of the Programs in Global Health at Columbia University's Medical School that goes by the name the Vagelos College of Physicians and Surgeons. Larry's a pediatrician and infectious diseases expert. His work is focused on viral diseases and drugs and vaccine development. Over to you, Larry, and thank you very much.
Thank you, Wilmot. Thank you, Murugi. Like the ones before me, I want to welcome everyone, and whether it's early morning, mid-afternoon, or late evening, thank you for joining us. Today's session deals with vaccines, COVID-19 vaccines, and we've, I think, assembled a really remarkable panel to have a discussion around the challenges that we're facing with regard to development, rollout, and uptake. So we have very pleased that we have just an outstanding lineup, but the keynote speaker is somebody who's extremely well qualified to speak on the topic of a Pan-African perspective on COVID-19 vaccines, and that's Dr. Shabir Madhi. Professor Madhi is a professor of virology at WITS University and a pediatrician. We seem to have a lineup of pediatricians today, which always pleases me. He's internationally recognized for his vaccine research, but he's also a bit unusual in that he's a vaccine educator and directs one of the very few programs internationally that provides postgraduate training for individuals interested in vaccinology. So very pleased that Dr. Madhi will lead off this conversation today. Shabir?
Thank you very much, Larry. And just as a bit of a correction, I'm a vaccinologist rather than a virologist.
Pardon me.
That's right. So good morning, good afternoon, everyone. And thanks for this opportunity to sort of share my thoughts in terms of COVID-19 vaccines, and particularly in the context of Africa. And obviously this talk is not going to be about the vaccines itself, but rather some of the challenges, as Larry has pointed out, that we potentially face with regard to the introduction of the vaccine on the African continent. And I think a good starting point is, and I'm sure this has been covered in the past 2-3 days, is just to reflect in terms of what our current understanding is when it comes to COVID-19 on the continent. And as you can see from the graphic, which you can download from our World in Data, Africa is really a blip in terms of the number of COVID-19 deaths that have been recorded. Despite the African population constituting roughly about 17% of the global population, currently they're responsible for just 5%, under 5% of all of the COVID-19 cases that have been documented, and about 3.5% of all of the COVID-19 deaths. Now, when you break that down further, and if you look at South Africa's contribution to the number of COVID-19 cases as well as deaths, is that despite South Africa's population constituting less than 5% of the African population, they're accounting for roughly about 50% of all of the COVID-19 cases as well as COVID-19 deaths. Now, there isn't anything exceptional of South Africa compared to many other African countries. I think that would be a misguided belief. What is really driving this, and I think sort of to emphasize that point, is sort of drawing an analogy between South Africa and Nigeria. So Nigeria has got a population that's about 3.5 times larger than South Africa, roughly about 190 million people. Yet the number of COVID cases that have been diagnosed in Nigeria is 1/10, even less than 1/10 of the number of cases that have been diagnosed in South Africa. And the main reason for that is that the testing rate in South Africa is sitting at about 62 per thousand of the population, whereas in Nigeria is sitting at about 1.5 per thousand of the population. So you've got a 30 to 44 lower testing rate in Nigeria. So it shouldn't come as a surprise that you're probably going to get much fewer cases as well as COVID deaths that are identified in Nigeria. Now, what it really tells us is that there's a systematic underascertainment in terms of COVID on the African continent, and that has got implications. It got implications when it comes to being able to advocate for the need of a COVID-19 vaccine on a continent, because at a surface value, there's very little need for a COVID-19 vaccine on the African continent if in fact there's so few cases, especially people dying from COVID-19. Now, South Africa, despite having the highest testing rate in Africa, only has a testing rate of about 60 per thousand. As an example, in the US, that's close to 250 per thousand now. In many other Northern Hemisphere countries, that testing rate sits at about greater than 150 per thousand. So we're lagging behind in terms of testing. So how accurate are we in terms of ascertaining the number of people that have died of COVID-19? And obviously this is not an exact science, but this analysis by the South African Medical Research Council shows that since 6th of May 2020, the amount of excess deaths from natural causes in South Africa is sitting at about 41,500, which is about 4 times higher than the number of people that have been diagnosed to have died from COVID-19. Now, not all of this excess mortality is from COVID-19, because I think our reaction to COVID has contributed to an excess in terms of mortality from non-COVID deaths. But my estimate is that the true number of people that have died from COVID-19 in South Africa probably is sitting closer to 30,000 rather than 13,000. So probably about a 2.5-fold higher actual number than what has been documented. And interestingly, despite this, and despite the number of cases that are being diagnosed in South Africa, what is intriguing in South Africa is that the amount of people that have really been infected, and there's some seroepidemiology studies that are coming through right now, indicates that in some urban metro areas, especially in the poor areas, the number of people that have been infected might be anything between 35 to 40% of the population. So the number of people that have been infected in South Africa alone, we probably currently have got an underestimate of at least 7 to 10-fold compared to what has been documented. And I think this is very much the same for most of Africa. Now, are there lessons to be learned from past pandemics? And obviously, most of us are familiar with the 2009 H1N1 pandemic. And this was an analysis that was done 1 or 2 years after the pandemic, and it was quite illustrative. In that during the pandemic, the fewest number of cases that were reported for swine flu were in fact from Africa and South Asia. In fact, they reported about 5% of all of the confirmed swine flu cases in 2009, 2010. Yet when they looked at excess mortality post-pandemic period, they estimated that roughly 50% of all of the deaths from swine flu, the 2009 pandemic, in fact occurred in South Asia and Africa. So again, during the pandemic, there was a systematic underestimation in terms of cases because of health systems issues, including extremely limited testing facilities. So in sub-Saharan Africa, 43 countries, they have got laboratories that are able to test for COVID-19. But those are generally countries that we have got a single laboratory, and it's not plausible, it's not pragmatic to expect those sort of settings to be able to quantify the burden of disease in those areas. So what happened with the swine flu pandemic? It's important for us to reflect, because history is meant to be a teacher to us, but we don't seem to have learned much, is that there was a rapid development in terms of the swine flu vaccine. Most of the development took place in high-income countries. No clinical trials were conducted in low-middle-income countries. South Africa was probably the only country in sub-Saharan Africa to eventually gain access to this vaccine, but it only gained access to the vaccine after the pandemic had passed. And this is pretty much where we're heading to, unless we bring about a change in terms of how we go about looking at a clinical evaluation of these vaccines, and when Africa actually starts playing a role in terms of that clinical development. So despite what happened in 2009 with swine flu, there was a flurry of activity, including being led by advocated by WHO and by countries, African countries, buying into the concept that we need to start developing manufacturing facilities on the African continent. The year 2020, 11 years later, there's not one country on the African continent that produces influenza vaccine, despite it having been earmarked as being a priority issue to deal with, because all of us were expecting the next pandemic to be a major flu pandemic rather than SARS-CoV-2. But despite that, almost no investment, and I'm not only talking of investment from the public sector, from government, I'm talking of investment on a part of the private sector. I'm talking of academics leading this sort of initiative, largely lacking, unfortunately, on the African continent. This slide is from 2011, but unfortunately, if I were to update the slide for 2020, it would be exactly the same. That gray will remain gray on the African continent. And this despite, in 2016, the coming together of the Ministers of Health, where there was a Addis Ababa declaration in terms of the need for Africa to focus on immunization and to basically promote regional investment in terms of development and production of vaccines. What's come of that? Again, unfortunately, almost nothing. We're sitting in 2024 years after the declaration. Not one country on the African continent, other than Senegal, which produces yellow fever, and Egypt that produces DTP, can lay any sort of claim in terms of having the manufacturing facilities to take on the development of COVID-19 vaccines. So we've got major problems on the continent, and those problems, unfortunately, to a large extent, are due to our own making, both in the public sector, in government, in the private sector, because of them not investing, as well as in terms of academia. And unfortunately, when it comes to academia, part of it is because of the loss of skill of African scientists to higher income countries. So I think all of us are familiar with the landscape of COVID-19 vaccines that are currently in the pipeline. And I'm not going to go into the detail of this, except to say for some of these vaccines, which are using really novel technologies, they're simply not suited for the African context. And, especially as an example, the nucleic acid vaccines, which would require storage as an example, at least for one of the two candidates that are in phase 3 studies at -70 degrees, something which simply is not pragmatic in Africa. The other nucleic acid vaccine candidate in terms of the pricing puts it beyond the reach of being accessible to Africa, besides which it's already been taken up almost in its totality for future manufacturing capacity, production capacity over the next 12 months by the United States. So we've got there's a number of vaccines that are currently in clinical development, almost close on to 30 vaccines that are in human trials. Now, despite 30 vaccines being in human trials, and many of these vaccines are really being done, multiple studies being done on the same vaccine. So I think the total number of vaccine studies that are currently underway is probably sitting close onto 60 to 70. And of this close onto 70 vaccine studies that are currently licensed, that are currently registered to be in clinical trials, only 2 are taking place on the African continent. And those 2 are the only 2 studies that are actually taking place currently in South Africa. So we're all familiar in terms of our aspiration to basically make history in terms of the timelines that it takes to develop a vaccine compared to the legacy of development of vaccines. And rather than looking at an average of a 10 to 15 year time span, we're looking at a 10 to 15 months time span. We might be successful in that. But unfortunately, where we're not going to be successful is expecting Africa in a 10 to 15 month timeline, which is really what is required to be able to up its game, to develop manufacturing facilities so that they're able to actually provide COVID-19 vaccines before this pandemic has passed. I think this sort of an aspiration is very misguided. And in fact, it doesn't do us any favors in terms of planning as to how Africa should go about accessing COVID-19 vaccines that might become available to the global community, hopefully in the near future. So, like I mentioned, many of the studies are being done, many clinical trials underway. This highlighting some of the phase 3 studies, of which one is one of the vaccine candidates is being evaluated in South Africa, and that is the University of Oxford vaccine candidate, the chimp adenovirus vaccine candidate. And then we've got some studies in phase 2, and of those, one of the studies has been conducted in South Africa, and that is a Novavax vaccine. Now, importantly, both of these vaccine studies wouldn't be taking place in South Africa had it not been the initiative of South African investigators to engage with those companies and University of Oxford to convince them for these vaccine studies to take place on the continent at an early stage. And it wouldn't have been possible had it not been because of funding that was provided by the Bill and Melinda Gates Foundation. And the reality is that despite there being a lot of sort of issues around Africans possibly being used as guinea pigs in terms of the clinical development of these vaccines, especially following the poorly informed utterances of the 2 French scientists, which was really related to BCG vaccine and it being evaluated in the African continent, that has led to some sort of protest, however very muted, in terms of why are we doing vaccine studies on the African continent. The notion that Africans are being used as guinea pigs, unfortunately, is completely misinformed. As I've already alluded to, and as this analysis shows from 2018, and the same sort of analysis that's undertaken in 2020 will produce the same sort of a result, is that despite the African population constituting 17% of the global population, less than 5% of all clinical trials are done on the African continent. Now, that low number of clinical trials that are done on the African continent, and many of these trials are actually done on the African continent only after the vaccines have been licensed in high-income countries. So there's a lagging period of time when these interventions are evaluated on the African continent. That comes at a huge cost. And the huge cost that it comes with is that during that period of time between which vaccines become available in high-income countries, and when the studies are completed in African countries before the WHO makes a recommendation for its use, leads to a huge amount of loss of life. And this is an example of a vaccine that was licensed in the 1980s, Haemophilus influenza type B, conjugate vaccine. And within 4 to 5 years after its licensure, 90% of high-income countries already had introduced this vaccine into their public immunization programs. On the African continent, it took 20 years since the introduction, licensure and introduction of this vaccine in high-income countries. It took 20 years before this vaccine was introduced to 90% of countries on the African continent and in Southeast Asia, in low middle income countries, 90 years. Despite 95% of the deaths that used to occur from Haemophilus influenza type B, which used to account for roughly about 350,000 deaths in the year 2000, 95% of that used to occur in low middle income countries, but the vaccine was simply not being used or accessible or in any way in low middle income countries for a variety of reasons. Over time, in 15-year period, when greater percentage of the population, childhood population were vaccinated, we see that figure dropping to under 50,000. It's not unique for hip conjugate vaccine. A similar sort of scenario played out for pneumococcal conjugate vaccine. It took 10 years between the time when a vaccine became available to children in high-income countries in the United States and Europe, before it became available to the majority of countries on the African continent and in South Asia, 10 years from the time when the vaccine was actually licensed in the United States. During that period of time, pneumococcus, which causes even a greater number of deaths in the absence of vaccination than Haemophilus influenza type B, estimated at about 600,000 in the year 2000. During that time, you can imagine the total number of children's lives that have been lost over a 15-year period because of the lag of introduction of these life-saving vaccines on the African continent. Like I said, the reasons for this lag in terms of introduction is not just only about the cost of the vaccine. It's about the reluctance of African governments to introduce many of these vaccines because of conceived lack of information in terms of how these vaccines will work or what is the burden of disease in their own countries, in the absence of them being able to quantify it, simply because they don't have the laboratory resources and the infrastructure to be able to quantify the burden of disease to start off with. So there are systematic issues which we faced in the past, which, looking at what's happening with COVID-19 in terms of reporting right now and the misrepresentation of what's taking place probably on the African continent, we're pretty much heading down the same sort of pathway in terms of there not being enough advocacy as to whether this vaccine, a COVID-19 vaccine, should be introduced on the continent earlier rather than later. So the reality is that Africa is poorly placed. It's way down in the pecking order in terms of being able to access vaccine as each individual country. And it's completely dependent on collateral initiatives, multilateral initiatives, one of which is a Gavi COVAX facility. And Helen is going to speak in a bit more detail on this. I'm not going to touch on it. But for many African countries, this probably is the only pathway to ensuring that they get at least a limited supply of vaccine at a relatively early stage, even if it's just for a targeted section of the population. But it still requires commitment on the governments to be able to buy into this concept. The deadline for subscribing to COVAX passed on the 31st of August. And I'm not too sure at this stage how many African countries have actually put forward the funds to ensure, at least especially middle-income countries that are not eligible for Gavi funding, how many of those governments have put forward the funds that are required to procure the vaccines, or at least to make an advanced market commitment in terms of vaccine procurement. So in addition to that, what we also face with is, as I mentioned, when it comes to influenza vaccination, there's pretty much almost absence of influenza vaccination in sub-Saharan Africa outside of South Africa. And even in South Africa, with a population of 59 million, we only use about 1.2 million doses of influenza vaccine. So there isn't any platform in terms of adult immunization on the African continent, including in South Africa. And that brings about a huge amount of logistics challenges in terms of its implementation. Then we face the issue that we're really going to be limited in terms of the quantity of vaccine that might become available through the COVAX initiative. The prioritization of these vaccines in the African context is not necessarily the same as it would be in high-income countries, where much of your mortality is occurring in adults at over the age of 65, as an example. In fact, what's driving the median age of death in South Africa is not 65, it's not 70, it's rather 55. And that mortality is being driven not because of people, the elderly, but rather because of comorbidities, especially undiagnosed diabetes, hypertension, obesity. So the prioritization of the use of these vaccines needs to be contextualized. But you're not able to do that in the absence of epidemiological interrogation of the status of COVID-19 in different countries. So we face challenges in terms of access, we face challenges in terms of implementation, we're facing challenges in terms of who to vaccinate with a limited vaccine that is going to become available. Last but not least, I think there's still a huge amount of skepticism as well as misinformation and misrepresentation of COVID-19 on the African continent. And overcoming that itself is going to be a major challenge in terms of vaccine acceptance. So thank you for your attention, and I'll pause at that point.
Thank you very much. That was an absolutely stunning talk. What we're going to do is, in keeping with the same pattern for the last few days, we'll go on to the panelists and have them provide their presentation and come back to a question and answer session in a little while. Our next speaker is going to be Dr. Scott Dowell. Dr. Dowell is a pediatric infectious disease specialist who's had a very long and remarkable career with the Centers for Disease Control, where he worked on infectious disease outbreaks and their control, among other things. And then in 2014 joined the Bill and Melinda Gates Foundation. And so, Dr. Dowell, we're looking forward to your presentation. Thank you.
Thanks, Larry. And good morning, good afternoon to everybody. It's early morning here in Seattle. And I thought about putting together my remarks on the Foundation's perspective on a vaccine for Africa. I wanted to say a few other things. And as you'll see, I'm going to reinforce largely what Shabir said. You'll see that Shabir and I think a lot alike. The vaccine is tremendously important. Never before in history has there been such high stakes for the development of a safe and effective vaccine and its use to control a pandemic and to save lives. And before I talk about the vaccine, I want to reinforce some points about the risks to Africa. Why has the impact been so low, much lower than I and many of us had estimated? And I'm going to reinforce what John Ngenkasong said a couple of days ago and what Shabir just highlighted today. There are several reasons why rates of COVID-19 are lower than we expected. I honestly thought there was going to be a wave of severe COVID-19 in Africa in June and July. In retrospect, there are a number of reasons why that was wrong, but that has not happened. The wave anticipated has been delayed. And the first reason for that, I think we should give credit to African public health leaders and Africans who were able to distribute diagnostic tests. Most countries were able to identify COVID-19 in their countries relatively early, and the response was robust and quick. There were shutdowns, there were lockdowns, and as Shabir and others well know, some of them were quite severe. But number two is the age issue. And Africans enjoy the age pyramid with very few people in the over 65 relative to other parts of the world. And the mortality curve for COVID is J-shaped. So it declines with each dropping decade of life, 60, 50, 40. And then there's a bend in the curve until it comes up in the infants. Slightly higher mortality, probably in the youngest infants. That bend is important because contrast to what even early projections were saying about the lower burden in places like Africa with young populations, it means that if you have a population in the age about 5 to 25, they are at very low risk of mortality. And as was pointed out at the beginning, 50% of African population is in the under 25. So that's tremendously important in the low mortality. But third, and really worth emphasizing, is the 50-fold lower rate of testing that Shabir emphasized. It's low testing because of lack of diagnostic tests and paucity of laboratories. It's also low testing because of restrictions, that self-imposed restrictions that countries have put on themselves. Most countries in Africa still require symptoms and or exposure to qualify for a test, and that severely limits the number of tests, even if testing capacity is there. So the projection burden, if we look at the IHME, the Institute for Health Metrics and Evaluation, projections for burden of COVID in Africa, most of the burden is in front of us, not behind us. We have months to anticipate increasing burden, and that is a concern. Despite that, it's important to say that the total number of deaths from COVID is not likely to exceed the death rates from HIV, from TB, from malaria. And so the fundamental public health interventions against those major infectious disease killers need to be maintained. It is unfortunately, I agree with Shabir that it is unfortunately likely, possible if not likely, that the true mortality of COVID on Africa will be calculated years later as it was for H1N1, and that would be that's the unfortunate situation we all want to avoid. We do not want to be in a situation where several years from now we belatedly recognize or confirm that there were lots of deaths in Africa and South Asia where they could have been preventable and we failed to prevent them. So vaccine development is tremendously important, and I want to just touch on the hurdles in the path of vaccine development for Africa. And this is our whole focus here at the Foundation, so we've been focusing on vaccine discovery, development, financing, manufacturing, approval, and delivery. And at each of those steps, there are potential hurdles for Africans getting protected by vaccine. On the discovery side, as Shabir pointed out, it's largely done. Wow, more than 150 candidate vaccines have been developed using basically 4 major approaches. In development, it's well underway. Again, as Shabir pointed out, we have, I was counting more than 9 phase 3 trials in humans right now. It looked like Shabir had maybe another couple, 2 of those trials enrolling patients in South Africa. So very good news and much faster than most of us had anticipated. On the financing side, there is, oh, what a mess. There's a lot of activity. Most of the financing are bilateral deals. The UK with one company, the US with several companies, deals with the European Union, the Russian vaccine, the Chinese vaccine, and so forth. All of these are bypassing Africa. Africans are not going to benefit from that. So it's the multilateral financing that is critical, and it is focused on the COVAX facility, the Gavi WHO COVAX facility that does 2 things. There are 2 types of multilateral financing that are important. One is for at-risk manufacturing. So financing the at-risk manufacturing so that the pool of available vaccine is large enough for everybody to access. And the second is procurement, these advanced market commitments that are being drummed up at the COVAX facility. And there's relatively reasonable progress towards the protection of healthcare workers and possibly the 20% highest risk populations. At this point, the rest of the population, it's not clear to me. Regulatory approval is going to fall to each country individually, and that is a potential significant hurdle and a mess, as Shabir pointed out. There is progress with AVRF and some of the other regulatory harmonization efforts that have happened over the last few years, and those things should help. We shall see how that happens. But then delivery. Delivery, as Shabir pointed out, an adult vaccine to the entire 1.4 billion people in Africa is going to be highly complex, and the work has largely not started. It isn't clear whether the traditional delivery mechanisms through UNICEF's countries, MSF and others, or if we have some of these new platforms like the African Medical Supply Platform, which is providing some disruptive, positive speed to the system, will be helpful. There's a massive need for local planning in each country, which is, again, largely not underway. And before I wrap up on the Foundation's perspective, I just want to mention, as we talk about vaccines, don't forget treatments. There are good therapies available and coming. We have oxygen, we have dexamethasone, remdesivir, not so helpful, but other antivirals in oral form, less expensive, are in the pipeline, and especially monoclonal antibodies. I anticipate in the coming weeks we are going to hear positive news about the efficacy of monoclonal antibodies. And although many of us think of them as unreasonably expensive, we are probably talking about $70 for a treatment course for somebody with a monoclonal. And if that is highly effective and it prevents mortality in a high-risk elderly or healthcare person, those kinds of treatments may save lives in Africa. I say may because, again, it comes down to delivery. There is a lot of work that would have to be done on the engagement of African leaders on treatment side, on the engagement with treatment guidelines side, and on the effective distribution of these treatments if they're going to have the impact that they could have or should have in Africa. So just to end with perspective on vaccines, this is our central focus. This is what many of the teams at the Foundation have been working on for the last 8 or 9 months, and it's the focus of the $350 million plus that Bill and Melinda have committed to this effort to speed COVID vaccines to those who are most vulnerable in Africa and elsewhere. Thanks, and I'll look forward to the other panelists and the discussion.
Thanks, Scott. That was terrific. I'd like to learn more about what you think the likelihood of those drugs being available anytime soon. So our next speaker is going to be Professor Helen Rees. She's the executive director of the WITS Reproductive Health and HIV Institute. She's a professor of obstetrics and gynecology, and she's internationally recognized for her research and policy work on HIV, vaccines, reproductive health, and drug regulation. Professor Rees is going to speak on the topic of the landscape of COVID-19 vaccine phase 3 clinical trials and phase 4 post-licensure studies across Africa. Helen?
Thank you very much. Well, in fact, having listened to both Scott and Shabir, I'm going to say a couple of things first, because Shabir was it introduced me as saying something about COVAX, and I'm going to put on some of my other hats, particularly in the African region where I chair the WHO. It's called the RITAG, the Regional Immunization Technical Advisory Group. So the first thing I want to do is start at a funny level, which is what Scott just said. Don't forget other opportunities beyond vaccines that are incredibly important. And I'm just going to highlight, it's not only treatment that we should be thinking about, but other prevention opportunities. And another study that's about to start in the African region, has already started in the US, is looking at the use of measles, mumps, rubella vaccine to give essentially an immune boost, and to see what that does to prevent new infections. So thinking out of the box, we're thinking COVID vaccines here clearly, but we're looking also at other vaccines. Other studies are looking at oral polio vaccine, and others are looking at BCG. So just to say, I agree, we shouldn't put all our eggs in a vaccine. The second thing I want to say, which is a general comment really, and this is with my WHO Regional Immunization Technical Advisory Group, short RITAG, hat on, was that when we had our first meeting about COVID, it wasn't about COVID vaccines, and this is a vaccine advisory committee for the region. It was actually about the failure of our immunization services because of the pandemic. And in one study in the Lancet, it indicated for every child that we avoided getting COVID by going into a clinic to have a vaccine, to have their general EPI vaccines, at its worst, if we stopped vaccinating children in our region for any prolonged period of time, we would save, for every one life we would save from avoiding COVID, we would lose 84 lives from vaccine preventable diseases. So that committee didn't focus first on COVID vaccines. It said, well, we have to restore immunization services. The third thing I'm just going to do is I'm just countering the discussions I've had in the last 48 hours, literally, with different groups. One where I was learning a lot about the kind of dialogue that's going on in the United States around COVID vaccines, which really surprised me. I mean, it's talking about states and mandates, and it's extremely granular, and it's got everyone engaged, but at an extraordinarily granular local political level. Now, I'm just countering that with my dialogues in the African region and in South Africa, and thinking about what are we worried about at the moment. Number one, we're worried about being left out, as Shabir's slide showed from the 2009 swine flu pandemic. We're worried about having the crumbs from the table and being left out. That's the first thing. The second thing, as people have said, we have the COVAX facility, and many African countries are what's called Gavi eligible. They're some of the poorest economies of the world, and therefore they can get support from Gavi and bilateral donors to purchase vaccines. They'll go into the COVAX facility with that backing them. But there are a lot of African countries that are middle income, defined as middle income, that will have to self-purchase. And the question here is, they're going to have to find, like South Africa, we're going to have to find an upfront payment for the COVAX facility in a context where the finances have gone down, our GDP, our economy has just sunk. So are we going to be able to actually even summon up sufficient to invest through a COVAX facility, which enhances people's fear? Because if we've got very little money, what is our risk appetite of going to a COVAX facility? But then the other side of that is what's happening is many commercial companies are having bilateral dialogue. The problem with bilateral dialogue with countries in terms of purchasing vaccines is that there is no transparency about what that cost per vaccine will be. And in fact, quite the opposite. Most of these dialogues are held with absolute secrecy. So other countries won't know that my next door neighbor country is paying half of what I'm paying. So and so that is a real threat. And so countries are, on the one hand, going through the COVAX facility because they're Gavi eligible. On the other hand, having to make these decisions about, with limited resources, what are they going to spend? So I'll talk a little bit more about some aspects now in my slides. I was asked, in fact, to talk about the vaccine phase 3 clinical trials. So on this, I put my hat on as chair of the South African Health Products Regulatory Authority. And for those of you from the US, it's the equivalent of the FDA. Next slide, please. So I'm going to just talk a little bit about this, but I'm also going to talk about some of the things that Scott raised around regulation. And here's the Washington Post's recent infographic, which shows us how many vaccines, 7 vaccines in phase 3. Shabir showed us this as well. But you can see the extraordinary number of vaccines that are coming through the pipeline. And of course, for those preclinical and early clinical vaccine trials, one of the challenges in the future, we hope, will be, well, how do we evaluate these vaccines if we have one efficacious vaccine? We had the same problem with Ebola vaccines. We had what's turned out to be a very good vaccine, the RVSV vaccine, which has been highly effective, very good in an outbreak situation, single dose. But then we had another vaccine coming close on the heels, but was unable to get clinical data. So how do you evaluate that vaccine versus a single dose vaccine where you've got proven efficacy and you've got an outbreak? These are very difficult because you never want to be left with just one vaccine as your choice worldwide for a pathogen of outbreak potential. Next slide. And here again, same thing from WHO, showing us how many phase 3 trials there are. And you can see that a lot of the phase 3 trials have come from the early development in China in particular. And of course, there's the Russian phase 3 trial that's also started. But the US, UK, are already engaged with phase 3 trials for other products. Next slide. So to sort of put this into a context of how we're thinking about how we address this, I just wanted to highlight something, and John and Kengason might have talked about this, but it's worth talking about it again. This fear of being left out has really galvanized political leadership, I believe, in the African region. I'm being the optimist in this crowd here. So we've really seen, for example, from the South African president, real leadership. We're currently the chairs of the African Union around vaccines and vaccine access. And the African CDC has also taken this on. And the aim is actually just to get access. This fear, once again, of having crumbs from the table. Next slide. With this initiative, there are 3 things that are being looked at. One is to accelerate African involvement in clinical development, quite the opposite from the fear of the guinea pig phenomenon, which is real and which we have to think about, and that's why we need strong regulatory authorities and ethics committees. This is a concern, but quite the opposite. I think that what many countries are feeling is indeed they're being left out of the research process. And yet, we really need to have diversity of representation globally if we're going to approve a vaccine that we say is going to have similar global impact worldwide. Then we have to have a look at the issue that we've talked about, ensuring vaccine supply, and then the scale up. And I'm going to obviously come with the phase 3 and 4 trials, thinking about the regulatory side. Next slide. So within this AU context, there are a whole series of things that are being done to try and strengthen our access in the region to participating in vaccine trials. And in fact, there was an article that was written recently in Science and published in Science at the end of last month, which was actually from a well-known academic in South Africa, Malakapura Makgoba. And he was saying that actually the dearth of African scientists who are publishing, who are engaged in this process, remains shameful. And we heard some of the data that Shabir said. So all of these things are under the AU's initiative. Next slide. But, and this is important, and Scott was saying it's a bit of a dog's dinner at the moment for how we align regulators. I don't disagree that we haven't got there yet by any means. But I have to be optimistic because I've been asked to chair a committee for this African Union initiative on regulatory research and ethical issues around clinical trials. So I'm optimistic that we will be able to get much more alignment. But it's not only alignment, it's actually speed. Because there's no good having an AVRF or a regulatory authority for the African Union if the wheels go too slowly and countries just say we'll do it ourselves. So actually trying to get sort of alignment, bearing in mind that there are different capacities of regulatory authorities is going to be very important. And this is one of the initiatives that we're looking at. And that regulation is important both for approval of clinical trials, but also later on approval of vaccines. Next slide. So I just thought, because I was asked to talk about this, it would be interesting to think about what are some of the issues specifically for COVID-19 vaccines that regulators will be looking for when we come to phase 3 and post-licensure trials. So first of all, we have to acknowledge that it's quite difficult to conduct clinical trials during public health emergencies. And this has had two impacts. One is that existing clinical trials in many settings have ground to a halt. And if you stop and pause and you think about the burden of disease in our region, it's had an impact on HIV, TB, malaria trials because of the pandemic. So that has to be restored and we've got to get those up and going. But the other difficulty is actually how do you do a clinical trial in a public health emergency beyond saying PPE for my staff? Secondly, like all other phase 3 trials, you're going to have acceptable preclinical and early phase studies so that you can characterize the safety and immunogenicity, but in a few hundred subjects. Importantly, and this is really important for our region, is that we have to include all the populations. So we want to have diversity. We've seen numerous examples where vaccines that might work well in one setting work in a different manner and have different efficacy, different safety profiles in other settings. It's very important that we get global data from a phase 3 trials. And also that we include the populations most effective, which in our setting, for example, we know from data from Cape Town in particular, that HIV, we have over a 2-fold increase in risk of disease. And same for TB, over a 2-fold increase. So we will have possibly different populations who will be most effective. We will be wanting to look at not only people who have got the vaccine who are SARS-CoV-2 naive, but we also are going to have to look at people who've had the infection, many of whom will have been asymptomatic. This is another peculiarity of our outbreak, which probably relates to age, but might relate to pre-existing immunity is that we've probably got many, many more asymptomatic people. And we're anticipating that when we do serology studies in some of our densely populated informal settlements, high-rise, multiple occupancy, that we're going to see high figures of people who've actually been exposed to the infection, might well not know it. Obviously, we will exclude anyone from a vaccine trial who's got acute infection. But one of the reasons why we would want to see this in both naive and people who've had infection, we want to see how this vaccine works, is that we are not, when we roll out a vaccine, we are not going to be testing people and say, have you had this infection or not? It's going to be to everyone. So we want to look at safety and we want to look at the response. Clearly, we want to look later on in a phase 3 trial, and probably weaving it in, we want to look at older adults, but also those with comorbidities. And it's interesting that the Oxford trial in our setting has actually already incorporated HIV positive individuals. And extremely important in all settings, but just as important here, is pregnant and lactating women and women of childbearing potential who might want a pregnancy. So the periconception period, and then pediatric patients, because pregnant women tend to get left always till last. And you'll often see in a package insert, this is the safety is not proven in pregnant and lactating women, and therefore they're then often excluded. And yet we're beginning to see an increased risk profile in terms of morbidity, mortality amongst pregnant women. Next slide. And the design is on the one hand, and we're seeing this with, for example, the Oxford study, the standard, what we would expect for a phase 3 trial, randomized, double-blinded, placebo-controlled, one-on-one, with standardized endpoints, safety monitoring that adheres to global standards. That will be the classical. And many of the bigger pharmaceutical companies are choosing already to go that route, and the biotechs, they're going this route of the classical design, which we can do at the moment because obviously we don't have a vaccine to compare to. But we're also starting to think about cleverer designs that will speed up a phase 3 study. And one of them is to evaluate multiple vaccine candidates against a single placebo. So one placebo, and then line up numbers of vaccine candidates against. And this this can be done provided you design your study up front to do it. These are called adaptive studies, and you have pre-specified criteria for when you add or you remove a vaccine. Then you can also have, and we're seeing this as well, seamless trials, where you might go from a phase 2 seamlessly into a phase 3 study instead of stopping, evaluating the data, have a gap, starting again, so that we speed up that consolidation of time from on average 12 years for a vaccine development down to 18 months, overlapping and seamless studies. Importantly, we would want to be able to follow up for probably 1 to 2 years if we can, because there are issues about safety, but also the duration of protection. And as we anticipate this virus is going to continue to circulate, understanding whether we need to give booster doses and how many and how often will be important. And there are things like enhanced respiratory disease that we're watching out for with these vaccines, particularly the newer vaccines that haven't been developed before or used as vaccines before, the newer technologies. Are we going to see some serious adverse events coming as the immune response to the vaccine wanes? And the other thing that we're going to have to think about is what happens if you're well on into a phase 3 trial design and then suddenly you get another vaccine that's said to be 40% effective. What do we do then for an ongoing vaccine study? Next slide. So this was the other question I was asked to talk about, is post-licensure. And this is going to be incredibly important, and this is going to be true worldwide, because it's very likely that we will not have as many participants in studies to look at in terms of safety that we would normally expect to have. So we would normally expect several thousand from the early trials before we go into a phase 3 trial. And then we would expect to have that phase 3 data to tell us about safety and adverse reactions. And so we really will have to have quite formal monitoring of safety. In that, we need to be sure that we capture subpopulations. What's going to happen for pregnant women in comorbidities? We might not have enough data when we start to roll out vaccines in certain subpopulations. We also need to, as I said, have enough time to follow up for some adverse reactions that might occur later, enhanced respiratory disease, for example. And importantly, what we will be asking for is a pharmacovigilance plan. which says, how are you going to monitor for all of this? And clearly in the African setting, actually intense monitoring is much more difficult than, say, if you're in a European or a US setting, a North American setting. So these are some of the things that we're really going to have to grapple with in order to participate in these trials and to do them safely. Next slide. The other thing that's very important is community engagement in trials. Excuse the typo there, but it's very important that not only do we take communities into these clinical trials, but also that we need to build up acceptability and demand. It's a point already been made. It's going to be phenomenally important. We've already had activists really banging on our doors and saying, we want to be consulted, we want to be involved. If we don't take communities with us through the clinical trial process, but also once we get to a point of post-licensure and perhaps phase 4 studies or some sort of post-licensure rollout, we could have a backlash that we had just not catered for. Next slide. So with that, that's just a sort of brief summary and overview. So thank you very much.
Thank you, Helen. That was, again, an absolutely remarkable talk. I hope we have time to come back to the issues around phase 4 testing, because it's one of the areas that we're very concerned about in this country. This rush to licensure, one can appreciate the need for that as people are dying, and so interventions that are effective are needed quickly. But there's a lot of suspicion, certainly in North America, around that question. So our next speaker is Dr. Stavros Nicolaou. He's Aspen Pharmacare's Group Senior Executive responsible for strategic trade development. He has over 28 years experience in South African international pharmaceutical industry. He's speaking on the role of the private sector in African COVID-19 vaccine response. Stavros.
Thank you, Lawrence, and colleagues. Good morning and good afternoon, wherever you might be. Many thanks for the invitation to participate in this esteemed panel. I have prepared some slides, and hopefully they'll start appearing on the screen. Okay, there we go. I should make a disclaimer up front in that WITS University seems to be heavily predominant on this panel, and I must confess that's my alma mater as well. So I thought I'd just declare that up front. I've been asked to speak about the role of the private sector in the COVID vaccine response. And that's pretty multidimensional, because it could be the private sector as in organized business. It could mean what is the healthcare industry or private healthcare industry, what views are taking on the response. So I've decided to go with a little bit of a hybrid approach, and I'm going to cover both aspects. But let me state up front that a vaccine is exceedingly important, not only for public health reasons, where we'd be saving lives, but it's an equally significant discussion with respect to saving livelihoods. And we've been following as a private sector very closely all the vaccine developments. We're aware and acquainted with some of the risks around overestimating or overestimating capabilities, but then also underestimating timelines. So we're very conscious of the perils and risks that reside in all of those conversations. But I think what's very clear for business is that our country here in South Africa and the rest of the continent could not afford to go into another hard lockdown and have economic survival, were we to look at repeating a hard lockdown exercise in the pre-winter season, which would coincide with March, April of next year. So we're looking very closely at some of the postulated timelines, and I think it's incumbent upon the private sector to be equally responsible in engaging those conversations. We've got some experience in that with the approach that we had with respect to serology-based testing and antibody-based testing. There was a lot of pressure brought to bear by business very early on that this should be introduced sooner rather than later. And I think there were those parts of business, and certainly we discussed these with Helen and SAPRA, there were those parts of business that said, look, we've got to balance the science with the business imperative here. And I think we've eventually got that right. And I would assume that the same conversations will prevail with respect to vaccines in the weeks and months that lie ahead. Can I get my next slide, please? So I've already intimated at some of the learnings of the last 6 or 7 months, and let me try and reinforce some of those. Certainly what COVID has brought to bear is definitely new macroeconomic and geopolitical considerations. We've seen a significant insularization, call it a re-emerging nationalism, if you wish. We've seen that countries, particularly rich countries, are very focused on solving the problem for their domestic population first, rather than a much broader global solution. We've also seen countries focusing significantly or placing their resources significantly on their own, strengthening their own healthcare systems. Now, you might say to me, well, that's a natural thing. But what it does do is it does further marginalize Africa, unfortunately. And then, of course, the PPE experience it laid there very clearly what a lack of domestic capability and capacity can mean, particularly when there's a frenzied scramble like there was for global PPE supply chains. And if those supply chains are constrained, you are left in the lurch if you don't have domestic capability. So in short, the way I kind of saw the last 6 or 7 months, and we shouldn't repeat this with vaccines, it was a bit like watching the favorite TV series, Hunger Games, where it's, you know, each man to his own, and it's all about your own survival and not the next person. So that's what we're up against as Africa. And I'd like to touch a little on the response of the private sector now, if I may have my next slide. Where does pharma sit at the moment, globally speaking? And then I'm going to zero in on South Africa and Africa more broadly. Firstly, we have seen advances in technology development over the last decade, 15 years. Step changes in new vaccine technologies have come to the fore. And it is possible to accelerate the development of both an efficacious and a safe vaccine in much shorter time periods. I think it was Prof. Madhi that had a slide that demonstrated how long it took to introduce some of the earlier vaccines to market versus what is quite possible right now. So I think the timeframes that are being bandied around for both a safe and efficacious vaccine is possible. The question is, how do you get industrial scale manufacturing so that you can make the vaccine readily available to all the citizens of the world? So vaccines still constitute a highly invested therapeutic area for pharma. It's in fact the 5th most highly invested. Of course, oncology still leads the pack. The next slide. Okay, so I've spoken about the efficacy, safety, and of course the timing aspect. So let's reflect on Africa and South Africa's capabilities with respect to the global scale that this vaccine is going to be required at, depending on whether it's a 1 or 2 dose. You would need a global scale of anything in excess. If it's a 2 dose product that you're looking at, you'd need in excess of 5 billion doses of vaccine to be manufactured. Now we know we don't have that global capacity as we sit here right now. Next slide. So to unpack that a little more in the African context, and I think it was Helen that made the point earlier that we've been through various iterations of pandemics on the African continent, and some have been more parochial and others less so, and some more specific and others less so. But what we know for certain is that we haven't really seized on many of the weaknesses that the continent has. And we don't seem to have learned much from those experiences. And I'm hoping the COVID experience will bring into sharp focus and contrast again the requirement to develop both local capability, capacity, and also manufacturing capability as well. So we know we've got limited to no R&D capability in terms of developing these technologies on the continent. We've got some technologies, but they're not at the level of sophistication or complexity that's required to start R&Ding biological products or even biosimilar products for that matter. We've got some clinical trial capability. I think certainly in South Africa, a pretty good one in my opinion. But the question then becomes, does that open a door for the country? So if we are one of the clinical trial arms for one of the studies here in South Africa, does that necessarily mean that we will land 10 or 15 million doses of a COVID vaccine? We have some sterile capability, and here I'll single out my company, Aspen. Aspen has invested significantly in sterile capability and does have the capability to manufacture vaccines, both liquid fill vaccines, and we also have lyophilization capability. We have both. And I think we would have, we have already applied for a license, a vaccine license, SAPRA. So I think there are companies like Aspen at a sterile capability level that are poised to manufacture the vaccine. Of course, let me move to the last point that I put on the slide there. Having capability and landing a product that gets licensed to you or contract manufactured arrangements, those require significant global networks. And I think Helen's alluded to some of those. I think Shabir did as well. So for us to get a COVID vaccine manufactured in Africa anytime soon, we would have to certainly leverage our sterile capability, as sparse as it is, link that up to our global networks, and link the technology to the manufacturing capability. And I think that's what we've got to unpack as South Africans and have started unpacking. How do we best leverage both our capability that we've got, as sparse as it might be, and the global networks that we have to ensure that the African population is not marginalized like it has been historically. Helen's posed a very interesting question, which I was going to pose myself, which is, let's suppose we land a vaccine for manufacturing in South Africa. And we also, of course, have another plant that can manufacture vaccines, which is BioVac. So you've pretty much got BioVac and Aspen in South Africa. Let's say we land a vaccine for manufacturing. Is that vaccine going to be affordable to the African continent? And I think that's a discussion we need to, we've started having that discussion, but we certainly need to accelerate that conversation. Next slide. Okay, so when we talk about the private sector in Africa becoming involved in vaccine manufacture, just in general terms and more specifically in COVID vaccine manufacture, I think these are some of the realities that you face. And I'm really reinforcing Helen's point earlier. That what have we learned in the last 10 or 15 years? So the first thing is to put up a vaccine facility is going to cost you upwards of $600 million. I think that's the first reality you've got to look at. The second is, will we ever have our own R&D capability where we develop our own vaccine, understanding how time-consuming these vaccines are, and if you've made a $600 million investment, you'd want to have built that into your payback period. Thirdly, of course, is always the safety studies and how rigorous they are, and very often these trials are very one-dimensional in terms of the population groups that get represented. And again, Helen made that point that these studies and trials have to be representative of a multitude of population groups from around the world, so that we're able to be absolutely certain around both the short and long-term safety considerations. Then, of course, the fourth reality is that there are long lead times in manufacturing these products, primarily because of the variability in demand. So the flu vaccine is a good case in point. Next season's flu vaccine would have started being produced already about 4 or 5 months ago, just to give you a sense. So if you're unable to consolidate that demand, it becomes very difficult to predict the volume that you require. And that's further complicated by the fact that because these are biological products in the main, there's significant batch-to-batch variability as well. So that's another reality on the African continent we've got to take into consideration if we are to embark on a serious vaccine manufacturing capability project. Of course, complexity of the regulatory environment and the manufacturing processes are certainly a major consideration, one of the realities. And that means having the right skills base on the continent that's able to manage these complexities, both in manufacture and the regulatory ones as well. A point was made earlier as well that most of these vaccines, if not all of them, require some form of cold chain management. And how well equipped is the continent to receive cold chain managed products? It's certainly a reality that's it's very important, practically speaking. I spoke about the batch variability, and there's two more I'm going to highlight, and that is that most of the 70%, in fact, of the production time of a vaccine on average resides with production time, QA testing, and release. So relative to making a tablet or a capsule, that's significantly high. And then, of course, lastly, probably the starkest reality of all is how do you get fair pricing, and how do you adapt those pricing models to the prevailing market conditions that reside. Next slide. Okay. So let me try and summarize where I think the private sector is in this whole conversation. And I also would have, in the short slide presentation that I've just delivered, I would have hoped I've given a sense of the realities that prevail, firstly on the African continent, and the challenges that need to be surmounted, and they're certainly not insurmountable. But if we don't start using the COVID pandemic as an opportunity to accelerate many of the things we've been speaking about for many years in Africa about developing our own capability, then I'm afraid the next pandemic or crisis will come along, and we'll be left in the lurch again in the same position. I've also demonstrated that when it comes to these global pandemics, very often frenzied global pandemics, it's each man to himself, as I indicated earlier. So I don't think Africa should be saying, well, you know, other parts of the world are going to come to our rescue. I think this is really the time now that we've got to start building our own capability and our own capacity. manufacturing or otherwise. And the best way, we've demonstrated this at Aspen. I mean, Aspen today is the largest manufacturer of anesthetics globally. One wouldn't expect an African country to be in that position. But we're able to do this by strengthening our manufacturing processes and capabilities, and also leveraging these global networks that I spoke about earlier. I hope, colleagues, that I've sufficiently emphasized the need to use this crisis to accelerate local capability and capacity. But I'm also hoping that we can use this crisis to try and reposition Africa differently with respect to both private and public interfacing and interaction to solve what is ultimately a common problem. And it's not just a public health problem, as I indicated earlier. As devastating as any public health crisis is if people have no livelihoods and you then create other issues, some of which will end up being health-related issues, but far worse, like social instability. So in summary, colleagues, thank you very much for this opportunity. Hopefully I've demonstrated that the African continent, certainly in South Africa, does have some manufacturing capability for vaccines. And it could be used, it could be turned on quite readily or imminently so if required. And hopefully I've also demonstrated that the challenge is going to be when you get this manufacturing going on the continent, how do you price it fairly, and how do you ensure that there are sufficient doses floating around in Africa to meet the needs of the African citizenry? Thanks very much.
Thanks, Stavros. It's a very interesting presentation. I think your issue around local production is an important one, certainly in this country. We've seen some failure of the global supply chain to be able to provide products that are needed. So I think the issues you're raising are being raised by a lot of people around a lot of different products. So, but thank you. So our final presenter this afternoon, this evening, is going to be Arnaud Bernaert. He is the head of Shaping the Future of Health and Healthcare at the World Economic Forum. He has over 25 years experience in healthcare industry, and is going to be speaking on the topic of the challenges of distributing the COVID-19 vaccine to billions of Africans. Arnaud?
Yeah, thank you very much, Larry, and I was very, very interested with the presentations of my fellow panelists, and a number of those things. I was going to hit on them, but maybe I can take a slightly different angle. At as a forum, I think obviously we've been involved on the field of vaccines for quite some time, and thanks also to the partnerships with the Gates Foundation. I think we were instrumental in the launch of Gavi in 2000, and more recently CEPI, the Coalition for Epidemics Preparedness Innovation, in 2017, with generous pledges in the first place from the Trust and the Wellcome Trust and the Gates Foundation, and Norway was also in the lead. Actually, CEPI is proving to be a remarkably important instrument those days, when you think that of the 9 vaccines in phase 3, actually Gavi is invested in 4 of them, which is quite remarkable, and not to even mention the ones that are in phase 2, such as Novavax. So that's where we're coming from, in a way. And I'd like to look into 5 different dimensions when it comes to getting access to vaccines for the African continent. I think the first thing is the profile of the vaccines being developed at this point in time. And yes, we can argue whether we have 7 or 9 in phase 3. I think the difference is that the J&J and the Sputnik vaccines are technically phase 3, but they have not started the recruitment of patients for the phase 3. That's why some newspapers would report on 7, but WHO would report on 9. Of the 9, let's look at the 9 now. We discussed Moderna and Pfizer's RNA-based vaccines, very, very complex cold chain issues, probably not very likely candidates to immediately benefit the African candidates, the African continent, not to even mention that the volumes have been totally pledged to rich nations, mostly so via BARDA contracts. So those ones are probably not very, very likely. Now we have obviously the AstraZeneca and J&J vaccines based on the same adenovirus platform, possibly very interesting candidates for Africa. But think about J&J distributing last year worldwide 300 million doses of vaccines and already pledging 1.2 billion of doses in the various contracts with rich nations, mostly so US and EU, Japan and Australia. That's going to be a very, very difficult challenge, and not to even mention AstraZeneca, that was not a vaccine manufacturer before the crisis, and in the collaboration with Oxford, obviously they had to secure a very large manufacturing footprint with Serum Institute of India, which, by the way, is going to pursue multiple pathways in the advancement of vaccine. I think in those cases, it's going to be really a question of vaccines availability in the number of doses. And it has been evidenced in the way, because, you know, if you look into the type of commitment that AstraZeneca has made, the only thing they have done by way of providing access to COVAX facilities, a 300 million advanced purchase commitment deal, and 300 million doses. So it's not going to be enough for the world, and certainly not for LMICs at large. So, you know, I mean, a part of me is thinking now that maybe the solution will have to come from China. And we know that there are free vaccines in China. I'm not mentioning the Sputnik vaccine at this point in time, because despite the fact apparently in the Lancet today they are publishing on positive outcomes, the problem there is the manufacturing capacity. You've seen the type of volume they can make at this point in time. They don't have a great access to manufacturing capacity, and again, Serum Institute of India is locked up now. I mean, they can't take anything more. So finding another large-scale manufacturer is going to be an issue. So but then there is also the profile of vaccines, because are they vaccines that are going to be applicable or effective on African population? Interestingly, the CanSino vaccine or the Sputnik vaccine are using a vector, the AD5 vector, that is the common cold virus, with which we have probably met a number of times, and it's very well documented, and including in the Lancet article today, that when European and Caucasian population may have 40% resistance to AD5, in Africa it may well be 80%. So even the vector being chosen for those two vaccines may be such that the candidates may not be sufficiently effective for African population, and at least it will deserve to run a clinical trial for African populations, which is not being done in the context of those two vaccines at this point in time. So you're left with 2 or 3 inactivated virus vaccines from China in the short future. At least this is what I think. Now, the second aspect is that last year the world produced 3.5 billion doses of vaccines, mostly diphtheria, TB, measles, mostly so distributed by the UNICEF Gavi channels. At this point in time, just to give a comparison, I mean, 2.5 billion doses have been pledged to rich nations in bilateral agreements, which obviously begs the question as to whether COVAX can survive without a significant increase of manufacturing capacity. And I think we deeply think at the World Economic Forum that there is an opportunity, still a short window of opportunity, to not only rely on advanced purchase commitment for manufacturers to make investments in increasing capacity, I think there are other things that can be done. There are different pairing mechanisms that can be done. And I think we think the IFC and the World Bank can certainly step into the plate, like they are doing with BioVac, by the way, in South Africa, to actually help capacity ramp up at scale and really create a network of large manufacturing sites. Start with fill and finish at this point in time. It's probably much needed, and certainly go into a viral vector, a drug substance in a second phase. Increasing the capacity of a manufacturer that is in the 50 million doses to 100 million or 200 million doses is not very, very costly. Interestingly, we're talking about $300 or $400 or $500 million investment on 4 or 5 global sites for a network of like this one to emerge. Put that in comparison to the need for COVAX to raise 20 billion to actually source vaccines. I think if you want to increase the probability of success of COVAX, you have to make that manufacturing investment right now. And that's what needs to happen in partnership with the developing country vaccine manufacturing network. We are in talk with DCVMN. We are trying to convince our friends from Gavi and CEPI that we should do that because in a way, I mean, CEPI cannot be at the same time trying to secure capacity for their own vaccines and at the same time using R&D money for their own vaccines and claim that they can run COVAX for sourcing all the vaccines. There is, in my view, an inherent conflict of interest in the governance structure of COVAX, and I shared very friendly, in a very friendly manner with Richard and Seth that opinion that it needs to be disconnected. Manufacturing and COVAX needs to be disconnected. Now, the fourth point I'd like to make, and it's going to be also an additional pressure, it has been mentioned before. If you look into the clinical trial protocols of those vaccines, I think you have typically endpoint about preserved immunity after 1 year or 2 years, meaning that you will never know at the time you start using a vaccine about the durability of the protection, which means that if you need to vaccinate people every year, I mean, this capacity issues never goes away, right? And that access to large volumes for regions like Africa become, in a way, endemic. So that's where you additionally need to increase the capacity. One thing that was not mentioned today, and I tell you, it's going to be, that's a time bomb. That's an absolute time bomb. The liability framework for manufacturers to actually provide access to the vaccines when vaccines are unlicensed is a very, very big deal. I mean, and you know, if you are J&J and you distribute vaccines in the US and there is an incident or series of incidents or accidents, I mean, J&J is not going to be blown away, right? Because the USA is functioning on the principle of immunity in the context of emergency use authorizations being granted. African countries can't do that. So the liability, no manufacturer is going to be willing to distribute the vaccines if they are on the hook for the liability of a large accident, considering that they had no time to run their phase 3. So that's not going to happen. That's going to be a very big concern because they're going to push on those countries to actually accept the liability, and governments in Africa will have to individually accept that liability, which is going to be a political nightmare for those nations and a considerable risk that will need insurance and reinsurance. The scheme is not ready. The industry is totally fractured, very different positioning from WHO. WHO is making the argument that the manufacturers need to retain that liability. The producers are going to push back to hell. So that's a big, big time bomb. It's not solved. It's not solved. And we have seen in the past, I mean, in the context of H1N1, it was going to impair population vaccination of population. We never got there. We were lucky, but this time we may well get there. And last but not least, and I love the opening from Dr. Tedros, I mean, public trust is also something that will need to be managed. We did run with Ipsos last week, you may have seen that in the news, and a simple question to 27 citizens in 27 countries. If there would be a vaccine, would you accept to take a shot? Well, you know, it's not great. 74%, which means 26% would refuse a vaccine. I mean, that's enormous in my view. And interestingly, think about that, 98% of the Chinese would take it and 54% of the Russian. So to think about the trust in government, I think Dr. Tedros cannot be more accurate when he says that we need to start working at community level to build that trust. So that's just to complement the views of others, but many similar items in viewpoint, I guess.
Arnaud, thank you so very much. It's just been a remarkable session. I just want to make one comment before we open it up to questions. It's something that really encourages me. I've spent, I can't tell you how many years working on the development of vaccines to control genital herpes. And we created a number of them that were safe and highly immunogenic and didn't work. And Helen and others in this panel have worked on HIV vaccines in the same story. So just because you make a vaccine that appears to be safe and appears to be immunogenic doesn't mean it's going to be efficacious. And I'm really encouraged by the fact that we've got so many candidates coming forward at the same time, because there's a hope that at least a few of these are actually going to be effective as well as safe and immunogenic. So I want to really thank this panel. This has been a most remarkable conversation. I wish we could go on for days. But we've got a number of questions, and I'll ask this panel now. We've only got about 15 minutes on the clock. If you can stay till 11:15, we'll keep going. If you have to drop out, we understand. So one of the questions that came from Dr. Veller, Dean Veller, has to do with the question of, okay, this is going to be expensive, but can a country actually afford not to invest in a vaccine? Is the cost of not investing in the vaccine greater than what it would do to the economy to make that investment? So your thoughts on that? And you're all muted at the moment, so if somebody's willing to take that question.
Well, I could have a first shot. You know, there's obviously a difference if we did cost effectiveness with the kinds of prices that are being floated, for example, through the COVAX facility. You know, perhaps for a country like ours, say $20 a shot. But if we did cost effectiveness, and if we did a cost effectiveness study that went beyond, as Stavros was saying, that went beyond just COVID, but also looked at economic activity, that what happens if we keep having waves of infection, it would be fine. It would win, I've no doubt. However, the problem is affordability, which is a different question. And risk appetite. Because in terms of risk, in the COVAX facility, countries who are self-financing have to put money on the table up front, anticipating that because COVAX is likely to be able to galvanize a number of different vaccines, that there's a very good chance that one or two at least should become effective, and that they would get a guaranteed up to 20% for their populations, but can ask for a larger volume. The problem is that is also at risk, because if you put your money on the table and things don't work out, you lose the money. On the other hand, as I said, if you do bilateral negotiations, that's always a very, very tricky situation. And some of the vaccines that are being put forward are going to be inevitably, just because of technology, much more expensive. So I think there are just those two things to think about. And that's why I think something like the COVAX facility is an important effort to try and level the playing field for all countries of all economic persuasions. But it does mean that all countries have to be willing to invest, and not just the poorest countries who are supported by Gavi and bilateral donors.
Thank you. We have another question that's interesting, and it speaks to some of the things that Shabir said at the very beginning and that got reiterated around the underestimation of disease across the African continent, infection and disease. And the question of at the pace with all of the things we've talked about in terms of barriers, getting it approved, getting it to manufacture, getting it distributed, actually getting it to the people. What are the likelihood, especially with younger people becoming infected, that you'll actually reach some level of herd immunity before a vaccine becomes available?
So I'll take a pass at that question. So I think that's a really important question. And I think there's recent evidence which actually indicates that it is possible that what we've observed in South Africa and to some extent in other African countries is possibly because of some underpinning immunity, probably induced by the common cold coronaviruses. It's actually allowing for, despite the high force of infection, it not really translating into huge amounts of severe disease. In fact, just today, there's an article from South Africa which indicates in women in the Western Cape that were admitted during labor, when they did seroepidemiology on those women, 40% of them were actually found to be seropositive. And interestingly, when we started our vaccine study, our COVID-19 vaccine studies, at the start, we were actually screening individuals to determine whether they were actively infected with the virus or not. And that was pretty much at the peak of the outbreak in South Africa. And 20%, and in one site, in fact, 25% of individuals that were being screened were found to be completely asymptomatic and PCR positive. So there's a huge amount of infection that has taken place. And I think to some extent, and I believe this has happened, is that cross-protective immunity possibly induced by common cold coronaviruses coupled with this huge amount of infection that's taking place, especially in the urban metros, has sort of almost lend itself in a sense to the sort of herd immunity evolving. The big question obviously is the duration of that immunity that's been induced with this infection. With a common cold coronavirus, we know that it might last up to 2 to 3 years. Whether it exists with this virus as well, that's the unknown. But I think it's an important question, but it all speaks to the need for epidemiological analysis, not just in South Africa, but the rest of the continent, in terms of understanding exactly where we are right now and what to expect moving forward. But I don't think it necessarily diminishes the need for a vaccine, because we're still going to have high-risk populations. And it's not that herd immunity is going to get rid of the virus completely. So we're still going to get a continuous circulation of the virus. There is a break in terms of chain of transmission, but I think there still remains populations that remain as susceptible for severe disease, even when that level of infection that might have taken place already.
I think those are all.
Could I add one other thing to that, just to build on what Shabir just said about the need for a vaccine? I think the other thing that we shouldn't think about is, well, phew, we got through this one. That's lucky, because we did that with SARS and to some extent with MERS, and we did it earlier on with Ebola. And so we get very anxious and concerned, and we put a lot of effort in, and then the thing goes away and we say, let's put it back on the shelf. And that's a problem, and we can't do that again. If you remember what happened earlier on in West Africa with the Ebola vaccines, these were candidate vaccines that had been stored somewhere. They were dug out, but by the time we got an agreed to trial design, we got them into the field, etc., we only got one trial that managed to get through to clinical endpoints. So I think that one of the lessons learned here as well is just because we've got herd immunity, we don't stop. We actually have to take these vaccines now through to a point where we think that they're likely to work for the reason Shabir said for this virus. But we also have to work on platforms and really continue that work so that we have the sort of plug and finish type antigen onto a platform for the future. And we can't stop that.
No, you're right. But I mean, that's been one of the great arguments in favor of the RNA vaccines, because you can plug and play. But as you point out, there are other challenges with that platform in terms of the cold chain requirements. So we haven't found the right one, in my view, at this stage. But nevertheless, all your arguments, I think, are cogent about why we need to keep moving on this.
Larry, I just wanted to make a quick point about herd immunity, which I think is important, and that is that it's a moving target. So I think people it's not widely appreciated that herd immunity can be estimated by 1 minus 1 over R naught. And if you do that calculation for the COVID virus, you get about 60 or 70% of the population has to be infected. However, what we're seeing is that we see effects of herd immunity much lower than that because it's R effective. And if populations wear masks, socially distance, and drive R down to 1.5 or so, you do the calculation, you can see that you see effects at lower levels. The important point that I think people should walk away with is because we're seeing effects of herd immunity at lower levels of population immunity, when people take their masks off and go about their normal business, herd immunity will go back up to 70, 80% or so. So it's a transient, it's a thin reed to lead on, if you will, and it's not something that people should feel comfortable, even if we're starting to see herd immunity effects. We still are going to need population-wide protection.
So in the case of a vaccine, because Helen brought this up, that turns out to be poorly efficacious, you know, something that slips through that's in terms of effectiveness maybe at the 40% level, but we've seen that social distancing, masks, avoiding large crowds, not attending large weddings in Maine, that you can really drive down the spread of the pandemic. So is this the equivalent of a vaccine for HIV that's 40% efficacious and everybody decides they don't need condoms anymore? I mean, could we have a situation where we've got some epidemiologists in the group, that this is really not a pretty picture from a public health perspective? I think that's the reason we've got to have these long-term studies. And as Helen was tasked with the question of what do we do around phase 4, I think there needs to be extensive, really robust phase 4 trials, because we need to know not only about the safety, we need to know about which of these vaccines seem to have the greatest durability. Anyway.
I think one of the bigger problem is if you get a vaccine at 40%, that's going to be terrible with the anti-vax guys, and the level of I'm talking about trust. How do you convince the population at individual level to take a vaccine that is 40% efficacious?
Well, I think. Go ahead.
Yeah, I mean, look, we got influenza vaccine that is not that great a vaccine to start off with. The effectiveness ranges anything from 25% to 75%. I think obviously I think a vaccine efficacy estimate on its own is sort of somewhat of a dubious sort of measure to use. It really needs to speak to the burden of disease that's preventable, percentage of population that's being infected. But I think more important than that, I think a vaccine that's got 40% efficacy in protecting against infection, upper airway infection, that vaccine is a winner. Compared to a vaccine that protects 80% against severe disease, but doesn't actually impact against infection. Because from a public health perspective, we're really wanting to interrupt the chain of transmission. And for that vaccine to work, you need to impact against infection or infectiousness at least. So I think a vaccine that has 40% efficacy against mild illness, that for me is a really successful vaccine. And then that same vaccine very likely is going to have much higher efficacy in terms of more severe disease. So I think when we're talking of efficacy, it needs to be put into the context of the endpoint that we're looking at and what that endpoint will translate into in terms of public health impact.
Sure.
I think the other thing to add to that is how likely are we to be able to retain all these non-pharmaceutical interventions in the long run, particularly for young people. I mean, it's young people who we see everywhere on Facebook who are out partying. You know, I mean, it is the nature of being in that age group. So I think we should just assume that there's only going to be a limited period of time where we can really try and enforce this. Therefore, we're going to have to weigh up that versus, having a partially efficacious vaccine. And I must say, a partially efficacious vaccine at 40%, I know that WHO is hoping for 50%. I think all of us would. But I think the modeling would be then extremely important. And it's also going to depend on your population, as Shabir was saying. You know, it depends on what's the severity of disease and who's transmitting. Therefore, what is that vaccine going to achieve? So there's going to be a lot of considerations in that.
Yes. So we have another question. It has to do with measures to ensure equitable rollout of the vaccine across the continent, especially with issues of corruption and mismanagement of the public purse. Anyone care to take on the issue of how do we make sure the people who need it actually do get it?
Yeah, I mean, obviously the issue of corruption is an elephant of its own, which I don't think we want to go into detail, but I think in the reality with COVID-19 vaccines, at least in a medium term, a short term, is that there isn't going to be much opportunity for corruption because the procurement is not being done. And I'm talking from a South African perspective. There aren't sort of middlemen that are sort of lending itself. So I think that's more or less of an issue. In terms of distribution, I think it's really for the NITEGs to basically right now work on development of a prioritization package for their own countries. And that eventually should influence who gets vaccinated. Easier said than done, but I think that's where NITEGs really need to come to the fore almost immediately so that work can be done before countries get whatever amount of vaccine that they're able to get over the next 6 to 12 months.
So perhaps I could just add to that, because I'm part of the SAGE working group that's looking at these vaccines and is talking about prioritization. And a couple of issues that have come up that are really very interesting, and you'll hear different geographical perspectives on it, is as you prioritize, do you put more weight on morbidity, mortality, or do you put more weight on maintaining the socioeconomic fabric? Because actually that will in itself feed back into reducing morbidity, mortality across all diseases. And if it's that, what do you think about heads of industry? And if it's that or other things, what do you think about prioritizing senior politicians? How important are they for political stability? So, I mean, it's very interesting once you start to unpack. Now, that's somewhat different to corruption, but it does talk to the values in countries, which will be different. And it comes back to what Shabir is saying. Ultimately, this is going to be a country decision. But there are many things, others, of course, like the military. Different countries will put different priorities on that. That's not corruption, but that is prioritization, and it will differ.
So it was interesting because Arnaud mentioned the issue of surveys of populations who've said that they're not certain they're going to take the vaccine or they're encouraged to take the vaccine. You're probably aware in this country that the Republicans are really very much against vaccines. And the funny thing now is that we're finding the Democrats, who are largely enthusiastic about vaccines, are sort of suspicious because of the speed with which the president is pushing the vaccine. So we could end up with a nation who actually has got a very low uptake rate, which I find perversely amusing. At any rate, so we've got another question I think is really quite intriguing because it speaks to what Helen was mentioning about COVAX, and it comes from one of our ethicists, Dr. Da. And it says manufacturers engaged with COVAX and at the same time approaching individual countries to establish bilaterals. How ethical is this double dipping in the midst of a pandemic?
Well, I'll start, others can come in because ethics, everyone can have a view on it. I suspect it's inevitable, and it's certainly widespread. So the bilateral negotiations between pharmaceutical companies and countries, that would be standard practice. That would be what they would do if there was a tender out for that they would go and bid. But what we're seeing is a lot of proactive approaches to governments to say, well, we'll give you this if you give us some upfront payments. And as I say, I think this raises a more fundamental question about the variability in pricing that we see for vaccines. And it was shown incredibly acutely with HPV vaccines, where even some very poor small countries in Europe were paying outrageous prices. So I think it raises a different ethical issue, which is all about access and pricing. We're seeing it with oncology drugs, not available in poorer countries because they're just priced out of the market. And historically, of course, we saw it classically with ARVs. So that let's keep that issue of pricing and responsible behavior from pharmaceutical companies. I don't know if Stavros is still there, because if he is, it would be good to hear from him as well.
Okay, let me, if I may, add one or two comments to that. I think the issue around access and affordability is an age-old discussion, and there are models that I think we need to refine. The ARV model that Helen speaks about is a very good one, actually, because at the start of the African continent coming to grips with the HIV pandemic, this is in the early 2000s, the average cost of a triple therapy ARV regimen was of the order of $5,000 per patient per year. It's clearly unaffordable in those days. And I think there were models that we were able to implement that allowed multiple tiered pricing, where you get one tier subsidizing the other tier. And eventually we brought, in 2004, we brought those prices down to $185 per patient per year. So I think there are different models that you can use, and very largely they lean on private-public subsidies. So I think we need to have that conversation around the COVID vaccine as well.
Thank you. Another question that's come in has to do with African nations, whoever's making decisions about the vaccines that will be selected for different countries, the extent to which they're having conversations with programs in Russia, China, the UK, and the US around not only securing access, but feeling confident that the safety data is robust enough. Are there any sort of offline conversations with companies, or is most of this consideration just using data that's available in the public sector? We're certainly seeing, and somebody mentioned the Lancet publishing data today. It looks like most of the data are coming up very rapidly. So my guess is that there's probably not a lot of offline conversations. I know most often the people really in the know are probably going to be the people in the data safety monitoring committees, and they're sworn to silence. So, okay, moving along. There was a question for, I think Dr. Sadi had to leave us. The question, and maybe Helen, you could help with this one, or Scott, the issue of what's the ideal outcome in terms of vaccine effectiveness in this case? Is it going to be one of preventing morbidity and mortality? Because that's certainly the public's perspective. From a public health perspective, what's your take on that question?
I'll just quickly jump in to say both, and apologize that I am gonna have to jump on my next call. But yeah, we have had a number of these discussions here about vaccines that prevent transmission versus vaccines that prevent mortality, and yeah, to me the simple answer is both are tremendously important and would be of great value. Before I go, could I just say I really appreciated the other panelists. I've learned a lot. One thing that I learned was timeousness. And if I could leave you with that word. When Shabir said it, I thought he misspelled the word. And then I heard, I think Helen and Nicolaou also used the same word. So I had to go look it up, and the wonders of the internet told me that timeous is a word of Scottish origin used mostly in the 1800s. And now really the only place it's used is South Africa. And so it's not a misspelling, it's a real word, but I think an important word for vaccines, because we talk a lot about volumes of vaccines that are going to be available for Africans. But the more important issue probably will be when in 2021 do Africans begin to have access to vaccines and get access to vaccines. If eventually everybody gets these 1 billion doses that we're hoping for, that's okay, but countries need to restart their economies. And so much of what we're focusing on is not just total volumes of vaccines available to people, the timeousness of that. When will they be available, and how soon can countries restart their economies because of the vaccination? So thanks for that word, and apologies that I have to jump to the next call.
Scott, thank you so much for joining us.
Yes, and just from Walmart, Scott, so thank you very much, and thank you for your leadership and the leadership of the Gates Foundation in tackling this incredible issue. So it's been remarkable, and thanks for joining us today.
Thank you.
And colleagues, I'm afraid I also have to drop. I would have loved to stay a little bit longer because this is a very inspiring discussion. I'm very hopeful that we put all together our weight in support of COVAX in the weeks to come. I think this is the instrument that can help the world big time. Thank you very much.
Thank you so much.
And thank you very much, Arnaud. We'll be in touch.
So I think we're losing our panelists, and they've been generous to spend a few additional minutes with us. So I think we'll go ahead and close out the session, and I'm going to turn it back over to Dr. James for some final comments. Wilmot?
So no, thank you very much. Thank you very much to our keynote speaker, to Larry, to the panelists. It was a remarkable discussion we had today. I couldn't have wished for anything better than what we discussed today, because we have an opportunity as a world, and we have an opportunity as Africa to actually do what we can to upscale preparedness for vaccine rollout on the continent. Let me just say that going back to the original aims of the symposium on the closeout, is that teams of us put this program together. It's not the work of one person, and there was a team at Columbia University, a team at WITS, and a team at the Africa Center for Disease Control, and also the broader network. So the Gates Foundation has been involved in that conversation, the World Economic Forum, the Wellcome Trust, and a range of other bodies. And there are three things we wanted to look at and assess. The first was the role of non-pharmaceutical interventions. They're largely social instruments and political instruments that countries have at their disposal in order to obtain public trust in adhering to and compliance with public health requirements in order to tackle COVID-19. That was the first discussion. The second thing we wanted to look at was the possibilities and limits of testing, tracing, and isolation as public health tools. And it's very clear that there are serious limits to it if the system doesn't work efficiently in all of its components. If test results come back too late, that tool is diminishing its effectiveness. And it's clear that that is an issue in a variety of places. And the third thing we wanted to look at was the question of vaccine development and vaccine distribution and all of the barriers associated with solving that. And having listened to the entire symposium, I'm left with a sense of agitation. And my sense of agitation partly comes from the fact that the science is known. It's an unfolding business. We don't know everything. We're learning a lot about this pandemic as we move along. But the public health science and the clinical science around COVID is shared globally in the community. There's no fundamental disagreement over that. The problem that we face is that the science take-up in terms of policy making and response is not where it should be. And it's particularly difficult on a continent like Africa with a low resource base, but where the response on the part of African nations has been extraordinary. The leadership has risen to the occasion. We know what the gaps are on the continent, and there are pockets of excellence scattered across the continent. To get where we need to get is going to take a heavy lift. We have to be bold. If you want to get involved in the vaccine side of what will come down, we have to, in fact, be able to, for example, find the $600 million in order to invest in a vaccine plant. There has to be an appetite for it. We have to get the economics right around it, and so forth. So I'm agitated partly as a politician. I don't think we're doing enough. I think that there's a broad unfolding community that is eager, that is willing, They would want to do much more. And I think what we need to do is build on that momentum. Chikwe Kwezu in the conference made a really remarkable point where he said that on the African continent, we see a rise in multilateralism under circumstances where many parts of the world are seeing a retreat into nationalism and a retreat into bilateralism in terms of dealing with an issue that requires a multilateral response. So I'm optimistic. I learned a lot during this conference from colleagues. I think that we tackled the issue we wanted to tackle. Our speakers have been first rate. I'm left agitated because I want to turn that agitation into energy so that we in fact take the next steps. And the next step is, I believe, it would have to be an effort to put the right people together around the table, not only to discuss, but to discuss a plan that would lift us from where we are presently into the next stage of preparedness for the science challenges that lie before us, and also to find the means to put together a plan to invest in Africa's manufacturing capability for COVID vaccine when it arrives. And that's not going to be easy at all, but I think it's entirely possible. So I leave quite optimistic. And so I'd like to thank Larry Stanberry for convening today's session. I'd like to thank everybody who participated in the discussions up until now, and also thank all the guests who've signed up for our symposium. To say that the supporters of the symposium, to reiterate, is the Columbia University's College of Physicians and Surgeons through Larry Stanberry, the Stanley and Marion Bergman Family Charitable Trust, which is based in New York, and Marion and Stanley Bergman have been fabulous supporters of our efforts. Stanley is the chairman of Henry Schein, which is the largest medical and dental technology distribution company in the world, and finally the Sanlam Foundation, which is a South African-based foundation linked to the Sanlam company. And with that, thank everybody once again, and I wish you a pleasant weekend.